be here, also has done a fair amount of this work. Here are my disclosures. So, is this the right talk here? Okay. So we're all aware of, as Don was alluding to, the benefits of lateral surgery, and the indirect decompression that we're able to obtain. And for me, in more complex deformity cases or multi-level fusions, the amount of correction, both in a rotational deformity or coronal misalignment, that we can obtain just from the first stage direct lateral alone. And that, I think, second point was the most impressive to me as I started doing more multi-level direct lateral fusions, the degree of correction that you were able to obtain in that first stage and what that could do in terms of enabling you to be more minimally invasive, say, for example, on your second stage posterior instrumentation. When we started to do a lot of these laterals, we looked at how we could be more efficient, especially in these multi-stage procedures, and started looking at single position options. Single position was faster in terms of OR efficiency. We didn't have to bring in a second bed and flip the patient. And when we started to look at some of those different techniques, we thought about whether or not we could do things to improve lordosis there. We looked at single position lateral, which really facilitated the lateral portion of the procedure, but the screw placement and posterior portion was quite difficult. Contralateral screws could be a challenge based on positioning of the patient on the bed, and utilization of navigation and robotics was helpful, but there was almost no ability to do a good posterior decompression, whether open or MIS. When we looked at single position prone, we started to think about how that facilitated the posterior work, the screw placement and the posterior decompression if necessary, but really had poor lateral ergonomics. And there were some parts that were missing, bolsters to impact against, for example, or bed positioners, allowing you to tilt the bed and maintain a stable position of the patient, as well as ways to provide some coronal bend to facilitate access to multiple levels. Some of the early limits with prone lateral surgery, I tend to do most of my laterals from a pre-psoas approach, so a direct lateral but pre-psoas approach where we'll mobilize that psoas muscle back. And in prone lateral, it's really difficult to do that. You're working not only with the psoas muscle against gravity, but the visualization is a bit more challenging as well. And so a lot of prone lateral, and the majority of those cases, are done trans-psoas. It's really hard to do long segment or multi-level direct laterals with the same efficiency when you have a patient in a lateral decubitus position. It can be a challenge with morbidly obese patients, and with single position lateral, like I mentioned, contralateral screws are a challenge. When we start to look at some of the data, there were some retrospective studies that looked at single position lateral versus dual position, and found that the dual position patients had a significantly longer OR time, which is not surprising, and 2 cases had reoperation for screw malposition in the single position lateral group. But there was no difference in lordosis or complication rate or outcomes between the 2. Other studies have suggested that there may be a decreased accuracy with fluoroscopic placement of screws in a lateral position, and this may speak to the benefits of advanced and enabling technologies like navigation and robotics. In single position lateral, the technical challenges of screw placement were noted in several studies, including difficulty of achieving that proper screw trajectory on the downside. Some folks early on were placing unilateral screws, just placing the facilitated upside screws. It really comes down to positioning of the patient on the bed and making sure that they're not so far across that the bed rail itself gets in the way with that trajectory. And it was also quite challenging with patients with any degree of rotational deformity, particularly if they were rotated down towards the floor as opposed to rotated up towards the side from which you were approaching your lateral. You're largely unable to perform a posterior decompression, and again, the familiarity of lateral positioning may outweigh the challenges with the posterior approach. Single position prone was described by Pimenta et al. Early on as a prone trans-psoas approach. It allows both lateral and posterior midline access to the spine. It's a single position with circumferential approach. You can do a lateral interbody approach with posterior instrumentation and a posterior decompression or osteotomies as necessary, really optimizing gravity to potentially improve lordosis, and can streamline your workflow such that at times multiple surgeons can be working simultaneously. Patient selection, indications, and contraindications were similar to direct lateral trans-psoas approaches, where the psoas anatomy and vascular anatomy considerations were the same. The positioning for a prone lateral is very familiar. These patients are placed on an open Jackson frame table. It's very familiar for your OR staff. As when I do my direct laterals in a lateral decubitus, I need to be there from the very second we turn the patient up to make sure that they're on the right point in the bed. I get everything taped where I want it, and everything's perfect. Here, the patients are going to be positioned in kind of a standard fashion on the bed. You have to be a little cognizant of the hip pads to make sure that they're not so high as to get into your working area. And the biggest thing is to be able to secure the patient well enough to get some tilt in the bed if you need to for improved lateral visualization. This can improve, the bed break can improve access at L2, 3, and 4, 5, where you have ribs or crests that may impinge. This also can allow, if you can rotate the bed enough with a secure patient, for an anti-psoas or anterior to the psoas or oblique approach. This positioning, again, with the hip pads at or below the PSIS, to maximize lordosis. A lateral bolster of some sort and tape for a lateral break around that bolster does help with access. And that contralateral bolster is the key to really keep that patient from bouncing as you're doing your disc prep or implant placement, as well as to allow the patient to remain stable if there's any degree of tilt in the bed. So here are some images with some early trials of bolsters. We would use extra hip pads with foam to make a robust enough bolster, and then tape the patient in kind of a triangular fashion across that. But you can see the access there in the image at left. Again, if you keep the patient in a true orthogonal position, you either have to raise the bed height significantly or provide some tilt, and the bolster does help to secure and stabilize that patient. Here are some images of a single position prone case. Certainly you don't want to spend your time doing what I'm doing there in the middle image. The ergonomics are just terrible if you don't do some degree of bed adjustment. The other nice thing here is that you can leave the AP fluoro in the field while you're doing your disc prep or cage placement, which can be somewhat helpful as well. For early experience here, we found that the psoas does tend to migrate more posterior in the prone position. It makes access at 4-5 in particular somewhat easier in a majority of patients. The retractor can tend to shift towards the floor with gravity and both with abdominal girth. There can be inadvertent ALL disruption or violation, which has been described as a result of some of that migration of the retractor. And so some folks have moved back to using shims with their retractors in these types of cases. The retractor depth is generally a bit deeper because of that abdominal girth and gravity, and it may be more critical in these types of cases to be concerned about the abdominal girth or the distribution of fat rather than the overall BMI, and those patients may do better in a lateral decubitus position. Navigation and robotics in single position prone is really advantageous. It can help navigate your trajectory and retractor positioning for your lateral, as well as facilitate disc prep and spacer insertion. It can significantly reduce radiation exposure both to the patient as well as the surgeons. And you can leave that AP fluoro in the field if you want to do final confirmation images or images of your implants or disc prep while you're working. And certainly without navigation or robotics, you can have significantly more fluoro than you would use with a standard lateral procedure. So here's a case example. This was a 70-year-old gentleman with low back pain, a radiculopathy and claudication that improved with sitting or lying down. He had a grossly antalgic gait and a straight leg raise, but was otherwise normal on exam and had failed extensive conservative therapy. He had severe spondylosis at the 4-5 segment, which you can see there with quite large lateral and anterior osteophytes with central recess and foraminal stenosis. And this gentleman underwent a single-level left-sided approach for L4-5 prone lateral with Perky screws and an MISD compression. You can see the final images here. He did quite well and was able to go home the next day. You can see that massive anterior osteophyte and not much height restoration there with the degree of spondylosis. Here's another example. This is a 68-year-old gentleman, again having back and leg pain, who underwent a left-side approach for L4, L5 LF with percutaneous screws, who went home the same afternoon at 6 weeks, was off of his narcotic pain medications, and was reporting 0/10 pain. And so, is prone lateral really ready for prime time? I think the early series indicate that it's a safe and reproducible approach, although their complication rates, I think, are related to the trans-psoas approach, which, again, I'm not that much of a fan of trans-psoas, particularly for multi-level cases. I think you can maximize access to the anterior and posterior column. and it's a good alternative to lateral transpsoas approach in select patients. For me, over 1 or 2 levels, and sometimes even for a 2-level case, I still prefer to have the patient in a lateral decubitus. I think it's a more efficient operation. And so I think, again, opportunity to streamline surgical access and potential to improve lordosis, although that remains to be demonstrated. There could be potential economic advantages with single position surgery with improved OR efficiency. And we need continued improvements with bed positioning, bolsters, retractor prepped instruments and interbodies, as well as the incorporation of technologies like navigation and robotics. And I think the interest has really surged in the last couple of years. I think it's right now for very select patients, but I think that could change. Thank you very much, and I'd be happy to take any questions.